Okay, so after the first, at the end of the first class, we were left with a few topics, which included the stone disease, which we'll cover at the end because there is nothing much very important in that, but just the questions that you usually get in your exams, and the malignancies, the neoplasms, carcinoma gallbladder, and extrahepatic bile duct tumors. So let us start with the more important ones, CAGB and extrahepatic bile duct tumors. So carcinoma gallbladder. Epidemiology, it is the most common biliary tract malignancy, as we all know, with the highest incidence noted in Chilean Mapuche Indian women, followed by women in North India. It is predominantly seen in female as compared to male, with a ratio of 3:1. This may be related to a higher rate of cholelithiasis and inflammation in women, although a direct causal relationship is not proven. More commonly seen in elderly patients, people more than 60 years. Familial CAGB is rare but not unheard of. Now, there are numerous risk factors, of which a few which we must keep in mind include inflammatory bowel disease with primary sclerosing cholangitis, obesity, to name a few. So let us now move on to etiology. It is seen that 75 to 90% of carcinoma gallbladder occurs in the setting of cholelithiasis. However, does this prove a causal relationship? No, it doesn't. Only 0.3 to 3% patients with stones develop carcinoma gallbladder. A lot of studies have been done on this relationship, and people have reported that more stones, heavier stones, increased stone volume, stone size more than 3 centimeter. These are all related to carcinoma gallbladder. But see, the end effect of all this is a chronic inflammation in the mucosa of the gallbladder, which will in turn lead to dysplasia, carcinoma in situ, dysplasia, carcinoma in situ, and then ultimately malignancy. So it is because of chronic irritation of the mucosa. So all these factors, like a heavier stone or stones, larger stones, it is not really very clearly known whether they really are related to, in a cause and effect manner, to carcinoma gallbladder. As we mentioned, genetic factors, there is one gene polymorphism, the cholesterol metabolism gene polymorphism, which is commonly noted. Other associations include presence of a bilioenteric fistula, presence of abnormal pancreaticobiliary duct junction, typhoid carrier state. These again, all typhoid leads to, and carrier state leads to an increased inflammatory reaction in the mucosa and subsequent changes leading to carcinoma gallbladder. Now, what about porcelain gallbladder? We all know that porcelain gallbladder is a pre-malignant condition, and the risk has been variously stated. Initially, in different studies, up to 20 to 30% risk has been stated. But now, finally, the risk is noted to be around 2 to 6%, mostly around less than 10% risk. And of the different kind of calcifications in the GB wall, which increase chances of carcinoma gallbladder, the stippled calcification is a stronger risk factor compared to diffuse intramural calcification. So now in this carcinoma gallbladder, it in early stages, it is very similar to in presentation to your chronic cholecystitis. Gallbladder may be distended with the tumor. It may be distended because of hydrops, or that is an obstruction at the level of neck or cystic duct level. It can also be contracted or collapsed. What is the most common location for carcinoma gallbladder? It is the fundus followed by body. Advanced stages of carcinoma gallbladder, which include the portal structures, will lead to jaundice, vascular invasion, hepatic atrophy, and may stimulate cholangiocarcinoma. A few special anatomical considerations about gallbladder, which needs to be known before we move on to diagnosis, management, and rather management options of carcinoma gallbladder. We know that gallbladder is partially intraperitoneal. It lies on the undersurface of segment 4B and 5 of liver. There is no peritoneal covering on the liver side. But what is there on that side is a condensation of Gleason's capsule, which we know we have studied in the anatomy section. It's known as a cystic plate. Now, in simple cholecystectomy, what happens is that we dissect the plane between the muscularis of gallbladder and the cystic plate. So that is actually inadequate for treatment of a malignancy. Now, what about body and fundus? These all lie away from the major inflow structures. So in this case, only a segment 4B5 resection is enough and a major hepatectomy is not needed. So when is a major hepatectomy needed? As we saw, when the tumor is in the infundible column of the gallbladder or in the region of the cystic duct, which is very close to the porta hepatis and involves the portal structures, a major hepatectomy will be needed because there is involvement of the vascular and ductal structures in the porta, in the region of the porta. So from this slide, what we gather is simple cholecystectomy is an inadequate surgery for lesions which are T1B and more. So we will come to all staging and what is T1B, what is T1A, what exactly are we supposed to do for each of them. So this is one point which has to be kept in mind when you consider the anatomical factors. Now, what are the different pre-neoplastic lesions? Just a second. Okay, can you all hear me? Hello? Hello? শোনাই যাচ্ছে না মনে হয়। Neha, am I audible? Can you find out? Because, oh, okay, I got some messages saying I am audible. Because initially some people were saying voices, there is no audio and all. Acha, okay, okay, okay. You're okay, okay, fine, fine, fine. Okay, okay, I'll continue. Yeah, thank you. Okay, so what are the pre-neoplastic lesions? Mucosa surrounding gallbladder cancer has actually been found to harbor high-grade dysplasia or carcinoma in situ in more than 90%. So these again are at a high risk of transforming into malignancy, into invasive carcinoma. And adenomatous gallbladder polyps are again ones which are known to be pre-neoplastic. Now, gross morphology. What are the different morphological subtypes of carcinoma gallbladder? It can be infiltrative, it can be nodular, nodulo-infiltrative, can be papillary, papillary infiltrative. Most are at least partly infiltrative. So that results in a diffuse thickening of the wall. Now, what is the speciality of this nodular type? Nodular types are usually circumscribed growth. So they are easily resectable. They usually do not invade into the surrounding structures too much. The same is true about papillary tumors, which grow large. But again, because of less invasive nature, they have a better prognosis. So histological classification, as we saw, we all know adenocarcinoma, the commonest, seen in 90%. Apart from adenocarcinoma, which has again a number of subtypes, including papillary, intestinal, signet ring, mucinous, adenosquamous, squamous cell, a long list of that. Squamous cell actually doesn't fall into it directly, but it is again another subtype. Apart from adeno, there are mesenchymal tumors, which include angiosarcoma, leiomyosarcoma. This is the table given in Bloomgart, which you can see. And there are other rarer tumors like melanoma and carcinoid of gallbladder. Of the genetic mutations that we initially talked about, numerous genetic mutations. So its expression in gallbladder cancer is not very high in all the studies, but the earliest event is carcinogenic genetic pathway is the P53 mutation. Now, based on the anatomical details as we saw, what is the pattern of spread of carcinoma gallbladder? It can have a lymphatic spread, it can have an hematogenous spread, it can spread through peritoneal cavity or biopsy tract. Now, carcinoma gallbladder invades and metastasizes early due to its thin wall of gallbladder, narrow lamina propria, single muscularis, and no serosa between the gallbladder and the liver. Now, once it has crossed the muscularis layer, it has free access to the major lymphatic and vascular channels. How does the hematogenous spread occur? It occurs from small veins extending from gallbladder to the portal venous system of gallbladder fossa. This which leads to segment 4-5 and 4b5 or segment 5 and 8. The commonest site of metastasis is liver, more than 90% seen in liver. Lymph nodal mets around 80%, peritoneal mets around 60%. Lung is the only common extra-abdominal site of metastasis, but it rarely occurs in the absence of an advanced intra-abdominal disease. Now, this is a very nice demonstration, representation of the pathways of lymphatic spread from a book by Professor Anil Agarwal. If you see this, finally all nodes drain into the interaortic cable. So what are the different pathways of lymphatic spread? There are 3 defined pathways which have been demonstrated by different studies injecting various contrast labeled molecules. What are these pathways? Pathways are cholecysto-retropancreatic pathway, which is the main pathway. And it is from the retropancreatic region, basically. So from here, the spread is along the hepatoduodenal ligament into finally the interaortic cable lymph node. Next is the cholecystoceliac pathway. And the least common is the cholecystomesenteric pathway, which reaches nodes at the root of superior mesenteric artery. And all these finally converge onto the interaortoceval lymph nodes. Despite all these 3 pathways being present, a direct spread to interaortoceval nodes from pericholedochal nodes is also seen to occur. Okay, so if you guys have any questions, I would prefer you don't put it in the chat box now, because during the class it will be a little difficult to answer. So if you could either message me directly or in the groups, I'll answer. Okay, so moving on to clinical presentation of carcinoma gallbladder. It has a varying range of clinical presentation. Patient may be completely asymptomatic, identified or diagnosed by final histopathological examination after a cholecystectomy for symptomatic cholelithiasis, or even asymptomatic cholelithiasis with a risk factor which mandates surgery. The surgeon may have an intra-op suspicion of carcinoma gallbladder. Why only intra-op? There may be a pre-operative suspicion as well. Now, what is important here is that during cholecystectomy, when there is an intraoperative suspicion, or even if there is no intraoperative suspicion for that matter, you should always open the specimen and examine the mucosa crossly. If you find the suspicious area, send it for frozen. Avoid gallbladder perforation or bile spillage. In any case, it is better to avoid it, but if there is a suspicion, then definitely it has to be avoided. As I said, very non-specific presentation. Early stage could be asymptomatic, present with symptoms similar to chronic cholecystitis, biliary colic. Advanced disease, however, may present with symptoms of weight loss, anorexia, jaundice. Labs, advanced disease, you may have raised direct bilirubin, conjugated hyperbilirubinemia, raised alkaline phosphatase, markers, carcinoembryonic antigen has a specificity of around 90%, but the sensitivity is only 50%. CA 19.9 is a more consistent marker than CEA. At levels more than 20 units per ml, the sensitivity and specificity is around 75%. Now, moving on to radiology. You must have had a detailed class on radiology of hepatobiliary system, so you would be aware of all this. However, we'll just cover the important points. On any patient with a symptom attributed to gallbladder or right upper abdominal pain, dyspepsia, any vague right upper abdominal symptoms, ultrasound is usually the first test. So what does ultrasound in carcinoma gallbladder? Echogenicity. Now, if there is a suspicion, in addition, of course, if it's an advanced disease, you may see a mass lesion, you may see evidence of extrahepatic biliary radical dilatation, presence of hypoechoic lesions in the liver suggestive of liver metastasis. All this may be seen. That all depends on the stage of the disease. Now, the next staging investigation is a triphasic contrast enhanced CT scan abdomen. Its main aim is in staging. It may show you a mass lesion not visible on ultrasound. It may show evidence of local extension or distant metastasis, evidence of omental metastasis, and for that matter, even duodenal invasion is difficult to assess on CT. For omental metastasis, a staging laparoscopy, and for duodenal invasion, an upper GI endoscopy are the best. Now, what about nodal involvement on CT? If you have nodes of the size more than 1 centimeter and ring-like heterogeneous enhancement, it has an 80% accuracy in diagnosing a malignant node. Apart from CT and USG, you have MRI and MRCP, which can delineate not only the gallbladder mass and its stage, local stage, but can also give us adequate information regarding the biliary tree anatomy. To diagnose metastatic disease and lymph nodal metastasis, PET scan has an important role to play. Although it's limited in differentiating benign inflammatory versus malignancy, addition of PET has been seen to alter management in about 23% cases. Invasive cholangiography in patients with jaundice, not for diagnostic purposes, only for therapeutic purposes. Here, I don't know whether you can appreciate, these basically are pictures from Blumgard, where you can see an irregular mass lesion in the wall of the gallbladder, a focal thickening more on this side than on the other sides. Similar here, and a PET scan of the same patient. Now, regarding PET, these are important from exam point of view. What are the causes of false positivity and false negativity? Now, false positivity, any condition where there is acute inflammation, acute or chronic inflammation for that matter, where these tracers are uptaken and they give a false sense of positivity, although the SUV values may differ, but then there is a high possibility that the SUV values may be in the same range. So false positivity and infection, adenomyomatosis, tubercular granulomatosis, xanthogranulomatous cholecystitis. It is very important to remember xanthogranulomatous cholecystitis because that is an important differential diagnosis in cases with cases with carcinoma gallbladder. Now, what are the causes of false negativity? False negativity in patients with diabetes, which actually these patients, their cells do not uptake 18 fluorodeoxyglucose, which is the main molecule involved in PET. So, because as we all know, in diabetes, uptake of glucose into the cells is impaired. Small lesions, mucinous lesions. Now, moving on after radiological investigation and labs, pre-operative pathological diagnosis. Is it really necessary? Do you really need to do an FNA or a two-cut biopsy from a GB lump where you have a suspicion of malignancy clinically as well as on imaging? Well, no, it is unnecessary. Because why is it unnecessary? Because it has a tendency to seed peritoneum and biopsy tract and surgical wound. It has significant false negative rates, so negative biopsy cannot be trusted. Apart from biopsy or FNA, bile cytology can be collected. It has a sensitivity of around 75% in detecting malignant cells, but that is only when an ERCP or PTC is being done and you have access to bile. Okay. This is the AJCC 8. Now we are moving on to the staging. Now this is the AJCC 8 staging for carcinoma gallbladder. You must see the AJCC 7th as well, just for comparison, so that if you might have a, like in my NCH entrance, I had a question which compares the previous AJCC with the latest AJCC. So the difference here basically is in N1 and N2. So previously N1 and N2 were based on location of nodes. Now N1 and N2 are based on number of nodes. So N1 is 1 to 3 regional lymph nodal involvement, N2 is 4 or more regional lymph node involvement. Okay, so now we have a patient where we have diagnosed on the basis of clinical examination, radiological investigation, that the patient might have a carcinoma gallbladder. So moving on to management. Before carcinoma gallbladder management, let us just have a few words on management of benign polyps, because these we saw are lesions with malignant potential. They are pre-malignant lesions. So this we already saw actually. Adenomatous polyps, although most common polyp have adenomatous polyps have malignant potential. Although most common polyps are cholesterol polyps, predictors of malignancy are size more than 1 centimeter, age more than 50, and presence of single polyp. However, a point to be noted here is that for primary sclerosing cholangitis, a patient with primary sclerosing cholangitis has a high prevalence of carcinoma gallbladder. So in these patients, polyps more than 0.8 centimeters are likely to be malignant. So the cutoff value is 0.8 rather than 1 centimeter. So whatever patient has polyps less than 1 centimeter, asymptomatic polyp less than 1 centimeter needs to be followed up with serial ultrasound. If there is an increase in size, present development of symptoms, then one has to consider cholecystectomy, depending on all other factors. If ultrasound-wise there is no evidence of malignancy, even for polyps more than 1 centimeter in size, laparoscopic cholecystectomy can be safely performed. One needs to have facility of frozen section, avoidance of perforation and spillage of gallbladder contents, and of course, a low threshold for conversion. So this kind of summarizes these findings. Young, pedunculated, no liver invasion, hyperechoic, more likely to be benign, solitary, more than 1 centimeter, endemic area, associated gallstones, more likely to be malignant. Now we will move on to the most important area of our interest, is the surgical treatment of carcinoma gallbladder. Before we move on to details depending on stage, I would like to bring your attention to one point. We very commonly use the terms extended and radical cholecystectomy interchangeably, but these are not synonymous. This is as defined by Professor V.K. Kapoor of SGPGI in his book on carcinoma gallbladder. It's an excellent small book, but of course, you will not have time to read all that now. Extended cholecystectomy is a well-defined surgical procedure which includes an en bloc resection of the gallbladder with a 2 centimeter non-anatomical wedge of liver along with regional lymphadenectomy. So how is it different from radical cholecystectomy? Radical cholecystectomy is an oncologically radical procedure, the extent of which may vary depending upon the location of the tumor and adjacent organ involvement. So it can be the same as extended cholecystectomy. It can include extended right hepatectomy as the extent of liver resection. It can include local wedge resection of the duodenum. It can include a colonic resection if that is involved. If the pancreatic head is involved, as we'll see the data, it may include an hepatopancreaticoduodenectomy. So extended and radical cholecystectomy terms cannot be interchangeably used. Depending on what exactly you want to say, you must use these terminologies. All carcinoma gallbladders, you have to do a staging laparoscopy. Why a staging lap? For identification of radiographically occult metastatic or locally unresectable disease, and it avoids a non-therapeutic laparotomy. After diagnosis of carcinoma gallbladder, after a simple lap cholecystectomy for suspected or unsuspected carcinoma gallbladder, like the patient has a stone disease and you do a laparoscopic cholecystectomy and find during surgery that there is a mass lesion, sent for frozen, turns out to be positive, you can actually do a laparoscopic radical re-resection provided you have the expertise. Okay, so next is incidental carcinoma gallbladder. There are two entities which you must remember. One is incidental carcinoma, which is diagnosed either at the time of cholecystectomy or post-operatively in a specimen resected for a presumed benign diagnosis. And missed is preoperatively, there was evidence of a carcinoma gallbladder. There was a mass lesion or there was a focal thickening of the gallbladder suspicious area, which we missed. So these are two different entities. One is an incidental, one is a missed. Now, when diagnosed intraoperatively, as we just spoke about radical surgery, if expertise is available, or you may transfer the patient or refer the patient to an expert center with expertise. It has been seen that the outcome is similar if done by the primary surgeon, provided he has the expertise, or by a surgeon with an expertise referred in another center. The outcome after re-resection are dependent in part on the T stage, with an excellent chance of long-term survival possible in early stage tumors. So, if you have a T1A lesion These staging you must see from the AJCC that I have put on one of the slides. T1A lesion, and it is margin negative. Standard cholecystectomy is adequate surgery. For all T1 with a positive cystic lymph node and all tumors which are T1B or greater, a completion radical cholecystectomy is indicated. For T2 or more, again, a completion radical cholecystectomy is indicated. This is all after cholecystectomy for incidental carcinoma gallbladder. But then the theory, the rationale behind all this remains the same. Even if you have a fresh case of suspected T2 or more lesion, you will do the same. Now, when do you do an extrahepatic bile duct resection? We'll come to that later, but just word on that here. When there is a positive cystic duct stump on frozen, of the predictors of prognosis, nodal status is an independent predictor of survival. If positive, the prognosis is poor. Staging laparoscopy, as we just saw, increases yield, factors which increase the yield of staging laparoscopy include poorer grade, increased T stage, and positive margin. This is again a nice flowchart, which if you see carefully, you have done a laparoscopic cholecystectomy for a presumptive benign disease. Okay, so if you note something suspicious or an obvious tumor at the time of laparoscopic cholecystectomy, you may choose to refer the surgeon to an HPV surgeon. Now, if the patient has been referred after laparoscopic cholecystectomy to you with the diagnosis of incidental carcinoma gallbladder, you have to stage the disease. You have to do cross-sectional imaging in the form of a CT, triphasic CT, assess the CEA, and study in detail the biopsy report of the gallbladder after cholecystectomy. If it is T1A, as we just discussed, with margin negativity, then this is adequate surgery. T1B, T2, radical resection. T3, T4, you have to do again repeat staging, a PET scan to rule out distant mets. Then, if it is a metastatic disease, then you send for medical oncology referral. Now, there are various controversial areas in carcinoma gallbladder. I hope I'm audible to all. Just a second. Okay, and not going too fast? Going fast? Okay. You want me to go fast? Okay, fine. So you are happy with the rate of speaking. Fine. Port site metastasis. This is another gray area. Maybe many of us during our MBBS days or final year MBBS or early MS days have seen patients with coming to us with small nodules around the umbilicus or the epigastric port site, and FNAC shows that it is positive for malignancy. And then we are at a loss as to what to do with the port site metastasis. Now, laparoscopic cholecystectomy, as we know, may result in tumor seeding of the peritoneum, port site, and subcutaneous tissues as a result of gallbladder perforation, bile and stone spillage, and seeding of laparoscopic instruments. Port site recurrence rates after lap chole range from 0 to 40%, and higher incidences are associated with known gallbladder perforation, which is very obvious. Now, at present, conflicting evidence makes it difficult to determine if port site resection actually is effective in preventing metastasis or prolonging survival. Port site resection. So what is the utility of port site resection, if at all? Its utility is for accurate staging of metastatic disease and has implications for prognosis and need for adjuvant therapy. So what happens if there is a gallbladder perforation during this procedure? If there is a perforation and gallstones are spilled, every effort should be made to retrieve the gallstones. This is actually true in case of all cholelithiasis cases. Peritoneum, abdominal wall adjacent to stones at re-exploration may be resected to remove a potential site of recurrence. This is also again controversial, but still a point which is given in the book. So if this comes as a true false kind of a thing, you can put it. In the case of spillage, some advocate washing the peritoneal and port sites with copious saline. Okay, so now we know what exactly we are going to do for each stage, each T stage. Fine. So we have mentioned everywhere about this radical cholecystectomy, which is an oncologically radical procedure and all that. So one option is an 2-centimeter non-anatomical wedge, which you take around the gallbladder, around the palpable margin of the tumor on the side of the liver. The other is that is a non-anatomical, and the other is an anatomical resection. So what is actually the purpose of hepatic resection? Why do you resect the liver? So basically, purpose is to resect tumors that have directly invaded the liver from gallbladder bed to prevent micrometastasis that may recur around the bed. And the extent is determined by the location of the tumor, fundus versus neck, morphological pattern of liver involvement, and extent of vascular bile duct involvement. Aim of wedge actually is only to achieve a negative margin for the primary tumor. So what about anatomical 4B5 resection? So it resects the primary tumor completely, and it also eradicates occult intrahepatic metastasis that may have developed through cancer cells spread along the portal tracts. So what are the different hepatectomies that might be required? T1A, T1B, okay, we saw up to T2, your 4B5 versus non-anatomical has the same outcome. If there is extensive liver infiltration or GB neck tumor with vascular or biliary involvement, which may require an extended resection, what are the options? Options are an extended right hepatectomy, or if the functional liver remnant is inadequate, you may also do a segment 4A preserving extended right hepatectomy. I mean, you do an anatomical resection wherein you preserve the segment 4A, take out segment 4B, 5, and the rest of part of extended right hepatectomy. So, right hepatectomy or right trisectionectomy. So, what does right trisectionectomy include? This you must have studied in your liver classes. Segment 4, 5, 6, 7, 8. So, these may be required to achieve complete tumor clearance. It all depends on the extent of portal structure involvement, extent of local involvement of the liver. So now, in these cases, you will have to increase the functional liver remnant. So how do you increase the functional liver remnant? One option is if you can manage to do a 4A sparing resection, but that may not be possible in all cases. So in that case, a portal vein embolization it may be a choice for patients scheduled for extended hepatectomy to minimize postoperative liver dysfunction. Laparoscopic radical cholecystectomy, we already saw for early carcinoma gallbladder, is being done in patients with enough expertise by surgeons with enough expertise. This slide I've just put to stress on one point, that why only 4B5 resection? Although I have told you before, I'm just reiterating once more, is based on the anatomical studies which has demonstrated that the venous drainage from gallbladder is predominantly into segment 4B and 5. And it is suggested that a bisubsegmentectomy prevents early metastasis via the cystic vein. So while the two options are comparable in patients, stress on this, comparable for patients with no liver involvement, most surgeons prefer to perform bisubsegmentectomy, that is 4B5 resection, for limited liver resection, limited liver infiltration. What about T3 tumors? T3 tumors, a standard radical cholecystectomy, including segment 4B5. As I told you, T2 or more, anatomical resection gives you better outcome. It is suitable, 4B5 resection is suitable, more suitable rather, if the tumor is involving the hepatic parenchyma, but is not involving the biliary confluence. Now, if you have a carcinoma gallbladder involving right hepatic artery, standard radical cholecystectomy is appropriate treatment as long as there is minimal biliary invasion, although extended right hepatectomy might also be selected as a surgical procedure. In such case, at times you may need to sacrifice the right hepatic artery without reconstruction. Now, lymphadenectomy. Second. When you begin radical cholecystectomy, the first thing that you do is, apart from you have done a staging laparoscopy, then you open the abdomen, again reconfirm your findings that there are no occult metastases which were not detected on staging lab. The first thing that we usually do is doing a inter-aortocaval nodal sampling. So if that is positive, send it for frozen. If that is positive, then you abandon the process. So what are the other lymph nodes that you would like to dissect? Hepatoduodenal lymph nodes, retropancreatic lymph nodes, common hepatic artery nodes up to the bifurcation of common hepatic artery and till celiac axis. At least 6 nodes should be dissected, and nodal disease, nodal positivity is associated with poor survival, which we have already seen. Now, if celiac lymph nodes are assessed and found to be positive, you abandon surgery again. Now, for locally advanced disease, again, a multivisceral resection can be performed in centers who have the facility to manage postoperatively these complicated multivisceral resections. So, duodenal, we will divide it into 3 parts: duodenal, colonic, and pancreatic involvement. So Miyazaki et al. Have classified the adjacent organ involvement in locally advanced carcinoma gallbladder into 4 types. It can be type 1, where there is hepatic involvement, with or without GI invasion. Type 2 will be bile duct involvement, with or without GI invasion. Type 3 will be hepatic and bile duct involvement, with or without GI invasion. And type 4 will be just the reverse, GI involvement without hepatic or bile duct invasion. So now, what if the patient has a duodenal involvement? Usually it's the D1 which is stuck to the gallbladder at that site. So if you have a suspected duodenal involvement on imaging, which we discussed that on CT, it is not very clear. So an upper GI endoscopy is required to assess duodenal involvement. You suspect that there's a duodenal involvement, the duodenum is compressed, you do a staging laparoscopy to rule out metastatic disease, and intraoperatively, if you find that really you have a duodenal involvement, then what are the different surgical options? If it's a small area of involvement, the resection of which will not lead to gastric outlet obstruction, then you do a duodenal sleeve resection. If it's a wide area but with no pancreatic involvement, you do a distal gastrectomy and proximal duodenectomy. If pancreatic involvement is present along with duodenal involvement, you must assess whether the area of contact is small. These are again the terminology small, wide are kind of subjective, but one has to follow these. If it's a small area of contact, do a wedge resection of pancreas. However, if it's a very wide area of contact, you have to do a hepatopancreaticoduodenectomy. So it is basically a radical cholecystectomy with Whipple's procedure. What about colonic involvement? Most commonly involved is the hepatic flexure, wherein you can do a sleeve resection of the hepatic flexure. If it's an extensive involvement, you may have to do a segmental colectomy or a right hemicolectomy. Hepatopancreaticoduodenectomy, as I told you, is combined hepatectomy with pancreaticoduodenectomy, indicated in very selected cases because of its associated high complication rates and mortality. Laparoscopic lymphadenectomy and liver resection, or rather laparoscopic radical cholecystectomy, is being performed by centers with the expertise, which I have mentioned a number of times. This is facilitated by the use of laparoscopic ultrasound. Now, again, a few points which you must keep in mind. If you have a carcinoma gallbladder with suspected common bile duct involvement, in the sense that you have, how do you know which are the cases where you have to resect the common bile duct? Is it routinely done? No, routine resection is not recommended. There is no evidence that it offers a survival advantage. It is indicated only if there is a direct involvement of the extrahepatic bile duct. Tumor or gross nodal enlargement close to or involving the common hepatic duct or hilum may also be an indication. Inflamed fatty HDL ligament, which renders nodal dissection difficult, is a relative indication. The most common indication for which all of us do extrahepatic bile duct dissection is a positive cystic duct margin on intraoperative frozen section, or obvious on palpation. You see that the cystic duct at the junction of cystic duct and common bile duct, common hepatic duct is thickened and suspected to be involved. Associated APBDJ, wherein we all know, and choledochosis, where we all know that the entire biliary tree, including the gallbladder, is at risk of malignancy. So you resect the common bile duct and do a bilioenteric bypass. Another gray area is presentation of carcinoma gallbladder with jaundice. Well, it is associated with higher disease stage, but it does not always preclude resection. Indication of preoperative biliary drainage in such cases is antibiotic-resistant cholangitis, malnutrition, hypoalbuminemia, renal failure, and most importantly, when the FLR is less than 40% of the total liver volume, and you are planning to do a portal vein embolization. What are the options? You can do a percutaneous transhepatic biliary drainage and endonasal biliary drainage, or if it's a low obstruction, you can put in a metallic stent. We will kind of end carcinoma gallbladder now with just a few words about adjuvant therapy, palliative therapy. Adjuvant therapy, it has been noted that 85% of the recurrences post-surgery are at distant sites. So gemcitabine plus platinum-based adjuvant therapy, GEMOX, erlotinib or epidermal growth factor inhibitors has not shown there is no difference in progression-free or overall survival. There might be a few questions on this, which is not covered in this part. I'll just go through them when I send you the questions, and then maybe mostly you don't need to know too much of details regarding these chemotherapeutic drugs. So what are the palliative treatments required? The most important things to palliate include pain, jaundice, Jaundice is complex, depends on location and extent of biliary obstruction. So options again, as we discussed, include ERCP, PTBD, ANBD. Indications, intractable pruritus, cholangitis, and before chemotherapy. Asymptomatic patient not planned for chemotherapy, no significant pruritus or cholangitis, you may wait and not go in for immediate biliary drainage. Pain, chemo-RT may be of help if the WHO pain ladder for pain control fails. Okay. So here we finish carcinoma gallbladder and moving on to extrahepatic biliary tree malignancies. We start with the benign tumors, which are derived from epithelial or non-epithelial structures that make up the bile duct. It is important to distinguish benign from malignant. They constitute around 6% of all extrahepatic biliary tree neoplasms, are slow growing, may present with obstructive jaundice, abdominal pain, nausea, vomiting, but no signs of malignancy like anorexia, weight loss. Okay. Physical examination is usually non-specific. Right upper quadrant tenderness, palpable gallbladder, depending on the site of obstruction of the extrahepatic biliary tree. Jaundice, investigations, MRCP is the gold standard. CT cholangiogram will also provide similar information. Endobiliary brush cytology has a high positive predictive value, but a very low negative predictive value for clinical utility. Benign biliary pathology may coexist with malignancy. So these tests actually do not alter clinical management in resectable patients. So this is the list of benign tumors and pseudotumors, all from Bloomgart. The most common is papilloma. So we just go through this one. Arises from glandular epithelium of the bile duct. 2/3 are polyps, adenomatous papilloma or adenoma. Slight female preponderance, average age is around 58 to 60 years. Majority of these, around 47%, are near the ampulla of Vetter. Presenting symptom in more than 90% cases is jaundice, which is intermittent in 40% because it's a kind of a ball valve kind of an effect. CBD exploration, if these are diagnosed at the time of surgery for, say, CBD stones, it is very difficult to detect that surgery because these polyps are soft, difficult to palpate, lesions presenting little or no resistance to exploring probes. They may be detected by intraoperative cholangiography. Choledocoscopy with low insufflation, of course, will be very useful. Radiographically differentiating from cholangiocarcinoma is difficult. ERCP will show a lobulated interluminal filling defect obscured by mucin accumulation in mucin-producing adenomas. Again, lesions in the lower common bile duct may protrude through the ampulla and be visible on side viewing endoscopy as well. So the etiology, suggested etiology, although the exact etiology is uncertain, it is suggested that it could be due to focal reactive process to injury. Treatment, as I just told you, is surgical resection. Choice of procedure depends on patient's age, medical condition, tumor location. Procedure most commonly done is a total resection of the lesion with some duct wall, and for lesions arising from the ampulla, a wide local excision. There is something called multiple biliary papillomatosis, which is a very rare disease. Presence of numerous mucin-secreting papillary adenomas within intra and extrahepatic biliary tree. Low-grade malignancy with propensity for local recurrence after resection. Histopathologically, fibrovascular stalk covered by a single layer of epithelial cell with apical mucin and minimal pleomorphism. Etiology unclear, commonly reported in Asia. there is a marked, just note this, it has a marked similarity between multiple biliary papillomatosis and IPMN of pancreas in histopathology, mucin production, and malignant potential. So WHO has coined a new term called intraductal papillary neoplasm of bile duct. The presentation is with intermittent jaundice, cholangitis, partial intermittent obstruction of bile duct by tumor fragments, mucus plugs and blood clots leads to intermittent jaundice. Associated CVD stone, gallstones may be present as a result of sloughing out of these lesions. Anemia may result due to bleeding. Diagnosis, again, MRCP, cholangioscopy, endoscopic ultrasound, and ERCP when performed for therapeutic purposes. Endoscopy, you can see a widely open papilla of Vater with mucin drainage, something similar to IPMN. Cholangioscopy will show multiple intraluminal filling defects which do not move with irrigation, thus differentiating it from stones and mucin. They may be present intrahepatically, extrahepatically, or both. So treatment, preoperative and operative cholangioscopic diagnosis, you do a choledochotomy, assess intrahepatic biliary tree by choledocoscopy. If it's a bulky tumor, curettage to identify sites of origin within bile duct, perform choledocoscopy of as many intrahepatic ducts as possible. If disease is localized to one side of the liver, partial hepatectomy, including all involved ducts. If bilateral system involved, curettage and internal drainage. Internal drainage, there is something special about it. You have to do a hepaticojejunostomy with a percutaneous access. Now, how does this access help? It helps in repeated curettage and in ablation with holmium laser. If you have a diffuse bilateral disease where none of these will help, then orthotopic liver transplantation is the last choice. Before we move on to malignant tumors, pseudotumors is a terminology which we must know what exactly they are. They are non-neoplastic lesions causing biliary obstruction whose preoperative diagnosis is impossible. Primary sclerosing cholangitis, benign inflammatory masses, lymphoplasmacytic sclerosing cholangitis will be associated. It can be a malignant masquerade. It is important that these lesions are not allowed to masquerade in the guise of malignant tumors, and more importantly, malignancies in them should not be missed. Okay, so now we will move on to extrahepatic bile duct tumors proper, malignant tumors. So they account for 3% of GI malignancies with an incidence high in some parts of Asia. They can be intrahepatic and extrahepatic. I will be covering only the extrahepatic part. So the most common site is the hilar cholangiocarcinoma, which accounts for 50% of all cholangiocarcinomas. Risk factors, well, majority are sporadic. Patients with primary sclerosing cholangitis have a 6 to 20% lifetime risk. Primary sclerosing cholangitis associated with ulcerative colitis, again, is at a higher risk. And performance of proctocolectomy for ulcerative colitis does not reduce the chances of cholangiocarcinoma. Okay, so the classification most commonly used for malignant strictures is the Bismuth-Colruyt classification, which is type 1, where the common hepatic duct is involved, type 2, where the confluence is involved, type 3, divided into type 3A and B, where the right-sided ductal system, left-sided ductal system, up to the secondary biliary radicals on this side are involved, and type 4, there is a bilateral involvement. Staging, well, again, this is the AJCC 8 staging. Just have a look and go through them. The lymph nodal number is again the same. Okay, so you will commonly see in different textbooks that the term perihilar cholangiocarcinoma is used. So what is a perihilar cholangiocarcinoma? It is not a pathological entity, but rather a practical disease entity. So it is defined as cholangiocarcinoma involving the perihilar bile duct. What do we mean by that? The ducts which are located topologically between the right side of umbilical portion of this area of left portal vein and left side of the origin of the right posterior portal vein. So this area actually is the perihilar area. Now, what are the risk factors? As BSc, we already discussed choledochal cyst. Mean age of presentation is earlier. Parasitic infections, clonorchis, opisthorchis, ascariasis. Just 1 second. Chronic hepatolithiasis or recurrent pyogenic cholangitis, exposure to thorium dioxide, not very common these days, but even then. Lynch syndrome, biliary papillomatosis, which have an 80% rate of malignant transformation. Most common site is hilum, as we discussed. Spread is longitudinal subepithelial manner along bile ducts and perineural and lymphovascular spread. Longitudinal spread extends in a plane which is deep to intact epithelium. Proximal spread of around 2 centimeter, distal of around 1 centimeter. Okay, someone wanted the previous slide to be explained. Which slide is that? Can you please mention, Lomesh? Which side? Perihilar. Yes, just 1 second. Okay, here. So it is basically, this is the left portal vein. You have, it is defined as located between the right side of the umbilical portion of the left portal vein and the left side, which is B, and this is X. The left side of origin of right posterior portal vein. Okay, this, I'll just, there's another picture which probably will help you understand better. Here, I don't know whether, I am able to understand this, but I don't know whether it's very clear to you or not. So it's B to X. Okay, this is right of umbilical portion of left portal vein. And here it is, where's my cursor? Left of origin of right posterior. This is the right posterior portal vein. Can you at least see this much? Okay. And now spread proximal 2 centimeter, distal 1 centimeter. So the margin of clearance needed is 1 centimeter for invasive component and 2 centimeter for non-invasive component for eradication of both. Now, most common type on histopathology is the sclerosing type, which causes annular thickening without prominent intraductal obstructing mass component. Other varieties, nodular, papillary. Papillary, we saw, is more common in the distal bile duct, expands lumen, less chance of invasive component, easily resectable, and better prognosis. Specific tumor types, difficult to manage, include the superficial spreading cholangiocarcinoma with non-invasive extension more than 2 centimeters, because these tumors require an extensive resection, because post-resection you want all invasive and non-invasive components gone. The margin should be free of both microscopic invasive and non-invasive components. This is easier in papillary and when differentiated grades who have a favorable prognosis. Now, the diffusely infiltrating variety have a wide range of irregular stricture, and the entire extrahepatic biliary tree is involved. So there is extensive infiltration, and trying to get a margin negative resection is difficult. So they are all good candidates for hepatopancreaticoduodenectomy. Now, multiple tumors in the bile duct are common in 5 to 9% patients. The criteria for multiplicity include no direct continuity between the two tumors, growth pattern typical of the primary, and a clear histologic difference between the two tumors. Clinical presentation, again, obstructive jaundice, most commonest, if it is type 1 or type 2, type 3 and type 4, of course, type 3A, 3B, patient may not develop jaundice, vague abdominal pain, anorexia, weight loss, pruritus, papillary tumors, you may have intermittent jaundice with tumors episodically sloughing out, causing intermittent obstruction. Examination, patient may present with jaundice, hepatomegaly, gallbladder is palpable when the mass extends distal to cystic duct insertion. Hilar cholangiocarcinoma, you will have a decompressed, non-palpable gallbladder. Okay. Labs, again, conjugated hypobilirubinemia, raised alkaline phosphatase, JGT, CEA 19-9 are increased, but they are non-specific, especially in the presence of jaundice. What are the radiological diagnostic studies? Ultrasound, first test in any patient with obstructive jaundice, ductal dilatation, Doppler may show vascular involvement. CT will definitely help you diagnose the site of the lesion and stage it. MRI, MRCP is the gold standard, greater sensitivity, specificity, accuracy than ERCP, definitely. May demonstrate occluded and blocked bile ducts not visualized by intraluminal cholangiography during ERCP. 80% accuracy in predicting dissectability. PET CT for distant and lymph node mets. However, its yield is low and false positivity for resectability is high. On ERCP or PTC, you may have rigidity, narrowing, tapering of the duct. Most perihilar cholangiocarcinomas are infiltrating tumors with direct and lymphatic spread, which evoke reactive fibrosis. Tissue diagnosis is not mandatory before resection. Remember this for all biliary malignancies for that matter. And a negative biopsy in the setting of high clinical suspicion does not provide any helpful data. So, preoperative management. Now we are gradually proceeding to management of such cases. So preoperative management, first you have to assess the patient's physiological state, ability to undergo major surgery, and of course the resectability of the lesion. So the resectability, what all do you have to assess? You have to assess the extent of tumor in the bile duct, vascular involvement, whether there is any atrophic hepatic lobe, and last but not the least, presence of metastatic disease. Now, lobar atrophy, hepatic lobar atrophy, when does it occur? It is usually moderate lobar atrophy when caused by long-standing biliary obstruction alone. Now, if there is occlusion of portal vein branches along with bile duct, there is more rapid and complete atrophy. On CT, the atrophic lobe appears hypoperfused with crowded ducts. CT, again, as we saw, we will look for distant metastasis, nodal status, distal classification, morphological subtypes, biliovascular anatomy, and another thing which is most important is the liver volume. Because here, again, an hepatectomy will be needed. So we need to assess the functional liver remnant. And all this assessment has to be done before a biliary drainage procedure. In a hilar lesion, a flat skin tumor, a perihilar lesion, we will always drain, this I'll come to a little later, proximal to the site of obstruction. So it will be most commonly, not always, a percutaneous biliary drainage, transhepatic biliary drainage. So better to assess duct prior to performing the drainage procedure. So on CT, portal vein invasion how do we define that? Because you have to have an idea regarding vascular involvement as well, because that will again one has to be prepared. If you have to do a portal vein resection, what kind of portal vein resection you have to do. You do not really need to know very great details about all that, but some idea is mandatory. Portal vein invasion, how do you diagnose? You can diagnose with an accuracy of 85% if defined as loss of the hypoattenuated layer between portal vein bifurcation and the tumor. You can do with the standard triple phase CT that we have a 3D portography, which facilitates design of resection and reconstruction procedure. So since most of these patients will present to us with obstructive jaundice, preoperative biliary drainage is very commonly performed. Now, what is the aim of this preoperative biliary drainage? It is to decrease jaundice, to increase the ability of liver to hypertrophy and regenerate post-surgery, to treat sepsis, improve nutrition, and last but not the least, to diagnose lateral tumor extension. However, it runs the risk of inducing cholangitis, especially in segments that are instrumented and manipulated, but not drained. So, randomized controlled trials in the West have concluded that a routine preoperative biliary drainage does not actually have any advantage. So, selective use should be done. So, if these are the aims that I have just stated, these are the ones that need to be met, then a selective biliary drainage procedure has to be done. So what are the options? Options are ERCP and PTC. PTC is a procedure of choice for proximal biliary obstruction. It is more accurate at targeting biliary radicals proximally. Bile duct on the ipsilateral side of the functional liver remnant should be drained. Clearer indications, pruritus, cholangitis before chemotherapy. And this is something, again, we must remember for access of delivering local therapy. Suppose the patient is locally advanced or unresectable. So after biliary drainage, apart from decreasing jaundice, we can use the drainage catheter tract for putting photodynamic therapy or brachytherapy. Photodynamic therapy, just a word about it. Photodynamic therapy is basically excitation of cells to release oxygen-free radicals, and this is done by using certain agents like delta immunolevulinic acid, which are taken up by cells, cause the cells to secrete, cause oxidative damage, cause cells to secrete free radicals, and these free radicals in turn cause aid in tumor necrosis. Now, if you're doing a pre-hepatectomy, this will be pre-hepatectomy, pre-hepatic resection, biliary drainage in a jaundiced patient. What is the target bilirubin before you plan to do a liver resection? The safest is less than 3 milligrams per deciliter. But if you have a sufficiently large functional liver remnant, suppose you're resecting the left lateral segment of liver, or you're doing a left hepatectomy and the right lobe segment 5, 6, 7, 8 is of sufficient volume, then for FLR purposes, at least preoperative biliary drainage may not be required. Controversies in this regard include skin tract implantation of cancer cells, spillage of cancer cells into peritoneum leading to carcinomatosis. So we spoke only of percutaneous drainage techniques because the success rate, as we saw, was higher for high bile duct obstruction. So what about endoscopic drainage? Though it is better tolerated, it lacks the ability to reliably target a specific area of liver for drainage and risks contamination of undrained areas. In this regard, an endoscopic ultrasound guided drainage may help. If you have an intraductal ductal papillary tumor, there may be tumor ingrowth and stent occlusion. So endoscopic drainage in such cases is never indicated. If it's for pruritus control, it may be done, but for a percutaneous drainage is better, because even a drainage of a single segment of liver is helpful in controlling pruritus. Cholangitis rarely occurs in these malignant obstructive cases unless the ductal system is instrumented. Post drainage, you should do a bilirubin 48 hours after drainage, which is more representative than doing it before that. Bacteria, that is presence of bacteria in the bile, is noted in 30 to 40% cases. Hence, pre-procedural antibiotics is required. If there is no cholangitis, continue antibiotics only for 24 hours post-procedure. So these drainage catheters, what do we do with that? Do we put it externally to drain the bile out, or do we what is known as internalize it? I mean, what do I mean by internalization? I advance the catheter through the ampulla of bladder into the duodenum. So if I do that, what happens is that the bile that I am draining, the obstruction that I am relieving, the bile is getting drained into the duodenum. So internal drainage is preferred to avoid bile diversion from intestine, because bile diversion causes impaired intestinal barrier function due to decreased intestinal cell regeneration and disruption of tight junctions between cells. Apart from this, use of ursodeoxycholic acid has also been recommended in such patients who have undergone external drainage. It provides protection against oxidative stress, inhibition of apoptosis, stimulation of bile flow, detoxification of coliphilic compounds, and immunomodulation. Perioperative symbiotics, pre and probiotics, has also been studied. Apart from ERCP and PTC, there is another procedure which is called the endoscopic nasobiliary drainage, which is recommended as the biliary drainage procedure of choice for perihilar cholangiocarcinoma. It has a low morbidity. Only when preceding endoscopic sphincterotomy is done is there a chance of post ENBD cholangitis. Otherwise, it has very less morbidity. But the only major disadvantage is spontaneous dislodgement of the catheter, because it goes like the rice tube through the nose into the biliary tree. Portal vein embolization, I'm sure you have studied in great details as part of your liver classes. But as we saw here, patients with insufficient FLR, we will need to do a portal vein embolization to enhance the hypertrophy of non-embolized lobe, which enhances safety of extended hepatectomy when needed. Ipsilateral approach preferred. Portal vein branch of the sector to be resected is punctured, to minimize the risk of vascular injury to the FLR. Right anterior sectoral portal vein is embolized. Remember this, as portal vein embolization indicated for patients undergoing right and left dissectionectomy or right hemihepatectomy. So you have to embolize the right anterior sectoral portal vein. The right portal vein embolization, a proximal 1 centimeter segment of vein must remain unembolized. Please note this, to facilitate division or closure of right portal vein during surgery. Embolization, what are the embolizing agents? You can use absolute ethanol, absolute alcohol, followed by steel coil. Alcohol induces endothelial injury and thrombosis. If after this there is unsatisfactory volume gain, which may be due to revascularization, you may repeat portal vein embolization. What are the second line interventions? Hepatic artery embolization of ipsilateral liver or hepatic vein embolization, along with portal vein embolization. Also selective intrahepatic biliary ablation. Intra-procedural issues, a few things which have been mentioned in Bloomgard also, and you should keep in has to be kept in mind for exam purposes. Right-sided approach preferred because right liver is larger, more accessible. Avoids X-ray exposure to operator's hand. This is very interesting because the operator has to do it from the left side if it is a right-sided approach. So it's a safer access. Only skin and right liver on the way. Disadvantage, discomfort of the intercostal catheter. When the tumor is above biliary confluence, isolating right and left duct and extending to secondary confluence or the second order biliary radicals on the right, then a left-sided approach is preferred. In Bloomgard, there's a lot of detail given about T-shaped stents, Y-shaped stents, but I don't think all that, at least I haven't come across in any of the exam questions. If any of you have any doubts regarding that or you want to know, just let me know. That is why I did not mention it here. Now, the more functional liver parenchyma can be drained by a single catheter on the left side. All this is done under ultrasound or fluoro guidance under conscious sedation. Okay, so we will now move on to surgical treatment of extrahepatic bile duct tumors. So what is the aim of surgery? Aim is a complete margin negative resection with re-establishment of bilioenteric continuity. 40 to 50% patients have been found to be unresectable at surgery. So staging laparoscopy here assumes importance. It prevents non-therapeutic laparotomy in 45% patients with radiological resectable lesions. Now, what are the criteria of non-resectability? We saw some criteria there, but they were not in great details. You have patient-related, patient-related factors, local tumor extent, this you must know, which is bilateral hepatic duct involvement up to second order biliary radicals, which is like the type 4, this was called type 4, encasement occlusion of the main portal vein, encasement occlusion of portal branch with atrophy of the contralateral hepatic lobe, hepatic duct involvement up to the second order biliary radical with atrophy of contralateral hepatic lobe. Basically, the atrophy of another sided lobe with another bile duct or portal vein involvement on the say side A, and that is side B. So if it is hepatic duct involvement on side A or biliary radical involvement on side A with atrophy of side B, means on the other side it is either a bile ductal involvement or a portal venous involvement. So both these, if you take into account all these four points, you will see why each is a contraindication. Now, distant tumor spread, metastasis to liver, lung, peritoneum, or distant organs, and lymph nodes outside hepatoduodenal ligament. So this is a very gross idea about what we want to do for each kind of lesion. If it's a distal third cholangiocarcinoma, we do pancreatic duodenectomy. If it is a middle third, people have done bile duct resection, regional lymphadenectomy. Although it may at times lead to margin negative resection, but a partial hepatectomy is almost always needed for better local control and improved survival. If it's an upper third lesion due to its proximity to other hilar structures, bile duct excision with partial hepatectomy and caudate lobectomy is essential. We will come to this caudate lobectomy shortly. Now, in patients undergoing R1 resection, actually have survival similar to locally advanced unresectable disease who did not have any surgery. So, moving on to liver resection options. Decision on which side of liver to resect depends on tumor location, vascular involvement, and lobar atrophy. Caudate lobectomy is recommended in all centrally located tumors as caudate branches actually drain into both right and left hepatic ducts. And caudate resection increases complete margin negative resection rates and improves survival. This is the image that I was talking about. This is also from Bloomgard. So what are the options? Option is a right or left hemihepatectomy or trisectionectomy with caudate lobectomy. Now, proximal duct resected. Just one second. Where's my cursor? This is the left portal vein. So the proximal duct resected. One second. At right side of umbilical portion of left portal vein here, in right hemihepatectomy, and in right trisectionectomy, it is resected on the left side. So right trisectionectomy, the site of resection is A. Site of line of transection, sorry, not site of resection. Line of transection is A, and in right hemihepatectomy, it is B. Now, what is the advantage? The left duct in right trisectionectomy is longer by around 1 centimeter, which is the width of the umbilical part of portal vein. Now, left hepatectomy, the proximal resection margin is at the level of right portal vein. And in left trisectionectomy, it is at the level of, just one second, I also got confused, right posterior portal vein. Okay, so which is P here. I don't know whether I'm able to explain or not. So left hemihepatectomy, the proximal resection margin is at the level of the right portal vein. Okay, so this is the right portal vein. And it is at the level of right posterior, this is the right posterior portal vein in left trisectionectomy. So again here, you gain some length on the right side by doing a left trisectionectomy and gain a length of around 7 millimeters. And on the right side, you gain on the left side, on the left ductal side, you gain a length of around 10 millimeter or 1 centimeter. Okay, so these trisectionectomies actually help you gain longer length of ductal margin in cases of perihilar cholangiocarcinoma. Okay, so just go through this image from Bloomgard, just read the caption, and you can always get back to me if there is any doubt, because somehow I don't know, even I'm not sure whether I was able to explain to you very properly or not. But you still just go through this, and I'll try to send you a write-up on WhatsApp. Now for bismuth 1 and 3, hemihepatectomies, 3 and some cases of 4, which are resectable, trisectionectomies. Right hepatectomy preferred for perihilar cholangiocarcinoma because it satisfies no-touch arm block resection, wide tumor-free margin, and favorable local control and better prognosis. Type 1 and 2, again, right hepatectomy. Bismuth Colbert 1, resection of extrahepatic biliary tree, cholecystectomy, portal lymphadenectomy. All this alone is acceptable for papillary tumors provided it is margin negative. However, it must always be combined with partial hepatectomy, right hepatectomy, in most cases, along with caudate lobectomy. Here also, all these things are with caudate lobectomy, okay, for better local control and better overall survival. Disadvantage of major liver resection, well, again, insufficient FLR, post-op hepatic failure, So in that case, a limited central hepatic resection is an option. I just remember the name. The disadvantage is that you have multiple bile duct exposed, but again, there is a way out. You can re-establish bilioenteric continuity by performing anastomosis similar to Kasai, portoenterostomy. There is something called a parenchyma preserving hepatectomy, which not necessarily is associated with decreased curability or poorer survival. It sometimes leads to better favorable outcome, wherein you can preserve maximum part of the parenchyma and resect. Portal vein resection in case of vascular involvement indicated if the tumor involves portal vein and is amenable to segmental resection, re-anastomosis or grafting. Patients undergoing empirical portal vein resection, as long as margin negative resection is achieved, improves survival. However, increased perioperative morbidity must be considered. Just a few surgical tips, which include that the distal CVD margin should be as you see here. The common bile duct has been divided and the whole extrahepatic biliary tree is lifted up. Should be sent for frozen, and nodes outside port HDL indicate distant mets. So tumor found unresectable after division and mobilization of common bile duct. What do? You do a Roux-en-Y hepaticojejunostomy using retrograde transhepatic biliary stents. This is for postoperative therapy, intrabiliary therapy, or photodynamic therapy, as I mentioned initially. What are the other modalities? Other modalities include orthotopic liver transplantation for locally advanced unresectable disease without lymph node or distant mets, intensive pre-transplant therapy, CTRT with new adjuvant intent is an option. Follows the Mayo Clinic protocol. There is improved survival, disease-free, and overall. To increase the FLR further, you can do ALPPS, typically for right trisectionectomy. Hypertrophy in this case is attributed to elimination of intrahepatic arterioportal, portoportal collaterals. You must have had a detailed discussion on ALPPS. Adjuvant therapy, controversial. I have just mentioned what is given in Bloomgard. I don't think you need to know more than that. Capecitabine, 5-FU, patients with high risk of locoregional recurrence, microscopically margin positive or N+ disease. These are the indications. Outcome after therapy, 5-year survival of around 10 to 40%. 40% very few. Strongest determinant is the margin status. Others include resected regional lymph node, whether involved or not, tumor grade, tumor histology, nodular sclerosing versus papillary. Papillary have the best prognosis. Now, what are the palliative therapy options? Jaundice in itself, as I told you initially, does not need any palliation unless there is intractable pruritus or cholangitis. Unresectability, if detected at laparotomy, you do a bilioenteric bypass. Segment 3 bypass has been shown to have increased patency compared to self-expanding metal stents. Drainage of at least 33% functioning liver is required to relieve jaundice. If it's an atrophic liver lobe or a liver infiltrated by tumor, drainage or bypass is not effective. Expected survival, if it is more than 6 months, you can put in a self-expanding metal stent. If it is expected to be even longer than and if the disease and the unresectability is detected at laparotomy, as we just saw, a bilioenteric bypass and hepaticojejunostomy should be performed. Photodynamic therapy, addition of this to stenting, increases survival by 2 to 3 months, improves biliary drainage. Cholangiocarcinoma, relatively chemo-resistant drugs, disease, locally advanced, unresectable, non-metastatic, as we saw, capecitabine 5-FU or 5-FU, locally advanced, non-metastatic, or metastatic disease, gemcitabine, cisplatin. Okay, so I hope I have been able to give you at least some basic information. If you have any queries, please feel free to message me, and I will give you an account of that perihilar definition, and with that image, difficult to explain here again. Okay. Now, the remnant of gallstone disease. Now, actually, we did not touch upon much of gallstone disease last time. So, since I don't wish to go into very great details, you know most of these things, and it's not very important from exam point of view also. Just the points which are asked in exams and parts from prior older exam papers. So, gallstone disease, what are the risk factors? Age increases with age. Pediatric population, if they have hemolytic disease, the risk is higher. Females, obesity, post-bariatric surgery, that is after weight loss. Patient on TPN, as we saw before, sludge develops in 5 to 10 days, and in 3 months' time, stone has been shown to develop. Low physical activity, 30% has genetic component, those cholesterol metabolism, polymorphism genes. Patients with cirrhosis, IBD, cystic fibrosis. Estrogen and progesterone have a slightly different way of increasing chances of gallstone disease. One is estrogen increases biliary cholesterol secretion, while progesterone decreases GB motility. So there is increased stasis and um, stone formation. Ceftriaxone behaves similar to, it has the ability to form stone-like structures, so it is called a pseudolithiasis. It leads to what is known as pseudolithiasis. Natural history, well, 80% are asymptomatic. Risk of becoming symptomatic is only 2 to 3% per year, and a complication rate is around 1 to 2% per year. So if it's an asymptomatic patients, when do you plan to do, what are the indications where you want to do a prophylactic cholecystectomy? This is, of course, an exam question. High-risk population for carcinoma gallbladder, those North Indian women, Mapuche Indians, and all those people. Patients with active hemolytic anemia, wherein if a patient has gallstones, and the patient has an acute cholecystitis, it is difficult to differentiate between an hemolytic crisis and your acute cholecystitis. So to avoid that diagnostic confusion, and prophylactic cholecystectomy is indicated during bariatric surgery, because after bariatric surgery, these patients will start losing weight, and we have seen weight loss during after bariatric surgery is a risk factor for gallstones. Patients undergoing surgery during or before renal transplantation. One second. Patients with porcelain gallbladder. We know what are the what are the different types of calcification for porcelain gallbladder, which we have already seen. Now, you know all details mostly about acute and chronic cholecystitis, and you hardly have any questions from them, but still the important points to be noted. Acute cholecystitis, commonest cause is an impacted gallstone at infundibulum or cystic duct. Leads to distension, edema, venous stasis in the gallbladder wall, ischemia, and hence necrosis. 20% cases, positive bile culture has been found, and the commonest organism to have grown is Escherichia coli, E. coli. Imaging, ultrasound, CT. If there is a diagnostic dilemma, ultrasound will show thick-walled gallbladder with pericholecystic fluid collection. Uh, there may be areas of hypoperfusion if there is some gangrenous changes. So these are the things which will again be more substantiated on a contrast enhanced CT. Associated with acute cholecystitis, the patient may have liver abscesses, so that also will be demonstrated on imaging. Now, if the diagnosis is not clear based on cross-sectional imaging of ultrasound and CT, then the next is scintigraphy. Okay. So what are the different agents which are used in hepatobiliary scintigraphy? It's commonly used ones are HIDA, DISIDA, PIPIDA. Not going into the full form, even I don't remember always the full forms. These are labeled with technetium. Normal scans usually delineate the biliary tree and promptly are excreted into the duodenum. So after this technetium labeled agent is injected, if it is seen that the gallbladder is not visualized, and one can assume that the cystic duct is obstructed, because from the liver it is excreted into the biliary tree, goes to the gallbladder, and a cystic duct obstruction in the background of the features of the clinical features or clinical findings that the patient may have indicates acute cholecystitis. This scintigraphy also evaluates gallbladder emptying. An abnormal emptying is referred to by an ejection fraction of less than 35%. However, for this to have any diagnostic accuracy, the liver has to be able to secrete this agent into the extrahepatic biliary tree, into the bile ducts, then the extrahepatic biliary tree, then enter the gallbladder. So it is not useful if the hepatic function is poor because of jaundice or because of some other hepatocellular disorder. So what is the treatment of choice? Initially conservative. You start off with conservative. IV fluids, antibiotics, antiemetics, analgesics. Definitive management is cholecystectomy. With increasing experience in laparoscopic cholecystectomy, it has been noted that lap cholecystectomy is safe. If a lap cholecystectomy is cannot safely be performed, then a lap subtotal cholecystectomy can be done. Other approaches include natural orifice transluminal surgery, single incision laparoscopic surgery. If the patient is a very high risk candidate for general anesthesia and surgery, one can do a percutaneous cholecystostomy, wherein the distended gallbladder is drained out and you put in a tube through under ultrasound guidance into the gallbladder, drain the inspissated static bile within the gallbladder or the mucus within the gallbladder. Now, once that is done, patient's pain, sepsis, etc., gradually decreases, and at an interval, a cholecystectomy can be performed. Now, timing of cholecystectomy, earlier it was always after 4 to 6 weeks of an acute attack. Sorry. But now it has been found that early within 72 hours and late at around 4 to 6 weeks. There is no difference in outcome or complications. Acute calculus cholecystitis, a few words regarding this. It is seen in patients with major illnesses like severe sepsis, trauma, extensive burns, in whom there is a patient is mostly NPO, there is no stimulus for gallbladder contraction, there is stasis, ischemia, sepsis. Critically ill patients, the signs and symptoms are masked by analgesics, antibiotics. Gangrene and perforation is common. Diagnosis is by ultrasound or CT. Scintigraphy with morphine it causes the sphincter of OD constriction and may help in diagnosis. Treatment is cholecystectomy or percutaneous cholecystostomy, depending on the condition of the patient. Now, how are these patients with acute cholecystitis graded? So the severity grading is as per the Tokyo guideline of 2013, wherein depending on certain clinical and biochemical and imaging criteria, they are graded as mild, moderate, severe. The details, you may go through them in this table. Mild cholecystitis, acute cholecystitis does not meet the criteria of the more severe grade. There is mild inflammation of the gallbladder with no organ dysfunction. Moderate is presence of one or more of a number of markers, which include the duration of complaints, more than 72 hours, palpable mass, elevated WBC count, marked local inflammation, in the form of biliary peritonitis, pericholecystic abscess, hepatic abscess, gangrenous cholecystitis, and severe ones is associated with dysfunction of any of the following organs, organ system dysfunction like the cardiovascular, neuro, respiratory, renal, hepatic, and hematological system wherein platelet counts are less than 1 lakh. 1 lakh. How do you manage these patients? Grade 1, you do elective cholecystectomy at an interval once acute illness resolves. Grade 2, 3, percutaneous cholecystostomy to tide over the crisis. Special cases, gangrenous cholecystitis, risk is high in diabetes and patients in diabetic patients and patients with acalculous cholecystitis. Results in necrosis of the gallbladder wall, most common in fundus. By definition, it is a full thickness necrosis. Free perforation may or may not be present. On imaging, you may be able to see air in the wall or lumen of gallbladder, intraluminal membranes, irregular wall, pericholecystic abscess, lack of neural enhancement. Other special circumstances, empyema gallbladder, where features are similar to intra-abdominal abscess, treated again by percutaneous cholecystostomy or cholecystectomy. Emphysematous cholecystitis describes a condition where there is presence of gas-forming bacteria in bile, which is most commonly Clostridium. They occur with acute or gangrenous cholecystitis, more common in men, diabetics. Ultrasound CT shows presence of air bubbles within the bile. IV antibiotics against Clostridium, followed by emergent cholecystectomy. Now, a few words about cholecystectomy in general. Not going into very great details. Indications for cholecystectomy, you have to divide it into symptomatic, asymptomatic. What is important from exam point of view is sometimes you have a question on asymptomatic cholelithiasis, cholecystectomy indications, which we already discussed, sickle cell disease, TPN, chronic immunosuppression, renal transplant patient. Just see this incidental cholecystectomy for patients undergoing abdominal surgery for other indications. Laparoscopic cholecystectomy, nothing really to mention. This is just for the sake of mentioning the details. Equipments, this is the list of equipments. This is what the operating room looks like. Technical issues, remember these small points which may suddenly arise in as one of the options. Pneumoperitoneum pressure should not be more than 12 to 15 millimeter of mercury of carbon dioxide. Critical view of safety reduces the chances of iatrogenic bile duct injury. There are two triangles. One is the triangle of cholecystectomy. The other is the triangle of Pallet. Triangle of Pallet is limited by the common hepatic, cystic duct, and the cystic artery here. The triangle of cholecystectomy is limited by the common, where is my cursor? Common hepatic, right hepatic, cystic, and the inferior liver edge. Now, in the hepatocystic triangle, only you should be able to, after dissecting the cystic duct and the cystic artery, you should be able to see, before you clip these structures, you should be able to see only the cystic duct and the cystic artery entering the gallbladder. So this is what is known as the critical view of safety. This has been described by Strasbourg. There was one question where it was asked who described it. So what are the contraindications for laparoscopic cholecystectomy? Absolute contraindications, refractory coagulopathy. Of course, this is true for all kinds of open and lap both. Inability to tolerate general anesthesia, hemodynamic instability, organ failure. More important because, as I told you, pneumoperitoneum decreases venous return, causes more hypertension, hypotension. Cirrhosis lap is preferred in child AB because of shorter post-op stay, fewer post-op complications. You must be liberal in the use of hemostatic devices. Now, gallbladder perforation. There's a classification called the Niemeyer's classification for gallbladder perforation, which divides it into three parts, three types. One is a free perforation, two is perforation with an abscess, three is chronic perforation with a cholecystoenteric fistula. So, one, of course, you do a cholecystectomy with a thorough lavage. Type 2, again, the same thing, drainage of abscess, cholecystectomy, lavage, cholecystoenteric fistula, if possible, a dismantling of the fistula, cholecystectomy, a closure of the site of communication with the intestine. So GB perforation is the most common intraoperative problem. It is usually secondary to traction by forceps and thermal injury by cautery. The stones are spilled, if the stones are spilled but not retrieved, and if they are pigmented, because we know the pigmented stone harbor bacteria, it may lead to localized abscesses as well. Okay, so that kind of finishes the important issues in gallstone. It is not an exhaustive coverage of gallstone disease, but I don't think from exam point of view for NCH, you need more than this. These are just the points which are from the exam questions. Now, CVD stone, the same is true here. There is no point in spending too much time on going in great details of CVD stone. CVD stones can be primary or secondary. Secondary stones are the ones which migrate from gallbladder. They are more common than primary, which originate in the common bile duct. They are more commonly, secondary stones are more commonly cholesterol and black pigment stones. Primary one, as I told you, originate in the common bile duct, predominantly brown pigment calcium bilirubinate stones. CBD stones in immediate post-cholecystectomy period are secondary stones usually, which have migrated into the CBD during cholecystectomy or maybe just prior to cholecystectomy and was missed. Patients present with pain, cholangitis, pancreatitis, jaundice. GGT is the most sensitive and specific lab test. Patients may present with a wide range of presentation with abdominal pain, jaundice, pruritus, cholangitis. You must know what is Charcot's triad and Reynolds pentad. Now, the critical component of therapy is biliary decompression. As an elevated biliary pressure secondary to distal obstruction induces cholangiovenous and cholangiolymphatic reflux, and hence the overt manifestation of systemic sepsis. For patients in sepsis, ERCP and stenting is done. Stone extraction actually should not be attempted because you must avoid excessive manipulation of inside infected biliary, extrahepatic biliary tree. After all this is done, the sepsis is settled and the patient recovers from the acute attack of cholangitis. Elective cholecystectomy at 4 to 6 weeks will be performed with either a laparoscopic CBD exploration if skills are there, laparoscopic skills are enough, open CBD exploration if skills are not there, and or you can do a preoperative ERCP followed by cholecystectomy. In preoperative ERCP, you will extract the stones because now in this scenario, the patient is not in sepsis, it's a cool condition. You can take out all the stone, keep the stent, do a cholecystectomy, maybe remove the stent during surgery or later. Now for acute cholangitis, again, there is the same similar Tokyo severity assessment criteria, which is almost the same as that for described for acute cholecystitis, apart from the fact that in the moderate grade, there is something called, they have included hypobilirubinemia, hypoalbuminemia, etc. as factors. Rest of it is mostly the same. Imaging for CVD stones, transabdominal ultrasound has a low sensitivity, especially for distal stones. MRCP is the gold standard. CT cholangio, again, is limited by suboptimal ductal opacification due to jaundice. Management, I have been reiterating a number of times since I started speaking on this. Laparoscopic cholecystectomy with lap CVD exploration, if expertise is available. Equivalent success rate for ductal clearance. This has equivalent success rate, but shorter hospital stay. ERCP stone extraction, high-risk group with multiple comorbidity. You can simply do an ERCP as a definitive management and forget a cholecystectomy. Silent CVD stones in 16 and 6%. What do you do with them? A patient simply comes with an with a CVD stone, no jaundice, no pruritus, no cholangitis, never had any symptoms related to CVD stone. So you can wait for 4 to 6 weeks because most of the time, more than 1/3 of the patients, the stone passes off spontaneously. What are the indications for open CVD exploration? Large impacted stones, failed previous endoscopic interventions. If that is there, actually after open CVD exploration, you must do a bilioenteric bypass because sometimes it can be ampullary stenosis or something big, which precludes endoscopic interventions after CVD exploration as well. So that again, if the patient develops a recurrent stone, you may find it difficult to manage. Anatomical with considerations that precludes endoscopic therapy, which precludes all kind of endoscopic therapy. Like if you have a Billroth 2 bypass done, so you are not you are unable to access the ampulla. When you do a transduodenal sphincteroplasty, when the stone is impacted at the ampulla, the anatomy is preventing endoscopic sphincterotomy. You have failed to doing endoscopic sphincterotomy. Pancreatitis, associated pancreatitis, chronic pancreatitis, wherein you are planning to do a ductal drainage anyway. Now, laparoscopic CVD exploration, this you must remember, this is a question. Primary method is the transcystic, so that what you do is you put in a guide wire through the cystic duct, first remove the gallbladder, do the cholecystectomy part, through the cystic duct, put in a guide wire into the common bile duct. So it is the transcystic common bile duct exploration. It requires, apart from the standard ports of laparoscopic cholecystectomy, an additional mid-clavicular line trocar for cystic duct access. Fails when the cystic duct is small, tortuous, obliterated, inserts at an acute angle into very distal CVD, or when there is a large impacted stone with significant inflammation. In such cases, you must do a transcholedochal exploration. So options when there are large stones, difficult stones for removal. You can do an endoscopic papillary large balloon dilatation and then retrieve stones, to mechanical lithotripsy, electrohydraulic lithotripsy, holmium Yag laser lithotripsy, and ESWL. After stone clearance, if the patient is high risk, only endoscopic sphincterotomy and stone clearance is enough. You may leave the gallbladder in situ. Okay, so we are about to come to an end to this gallstone business. Post cholecystectomy problems, just a few words, nothing much about it. divided into immediate technical problems. We have discussed all of them in these two classes. Delayed technical problems. Again, we have discussed biliary stricture in great detail, spilled stones, etc. Functional problems, sphincter of OD dysfunction and post-cholecystectomy diarrhea. Extrabiliary disorders like peptic ulcer disease, liver disease, IBS, post-surgical adhesions, and psychosomatic disorder. So this is a nice table given in Bloomgart about the management algorithm. So just go through this. There is no point in just reading it out because each of them is about a particular problem that one may face post-cholecystectomy. If there is a sizable fluid collection, aspiration, drainage, rule out biloma, bile duct dilatation, abnormal LFT, do an MRCP, CBD stone, ERCP, and stone extraction. No evidence of biliary pathology, do an axial imaging to rule out other causes. Here again, fluid collection, rule out biloma, bile leak suggested, then ERCP, rule out bile duct injury, manage bile duct injury as depending on the type. Biliary dilatation, CBD stone, you can diagnose whatever is the etiology, biliary stricture, injury, stone, GB remnant stone. You can do a definitive surgical management, can do a completion redo surgery, cholecystectomy, removing the remnant gallbladder. So that is all. So whatever questions you all have, because this question box will disappear after this class is over, I think. So can you just write it down and WhatsApp me? So that will be useful. I will send you all answers to whatever queries you have. And I hope I was able to explain things to you and the class was helpful. If you want any other specific topic to be discussed, just let me know. I can give you things in writing on WhatsApp as well. Okay, thank you. You want me to explain this? Slide 118, someone said. Please show 117 and 18. Okay. What happened? Just 1 second, I'm unable to show you. Yes. 118, what is the doubt? The primary method of laparoscopic CVD exploration is through the cystic duct, that is the transcystic. So, what is the extra port that you need for this? It is the same as during laparoscopic cholecystectomy. You just need extra mid-clavicular line trocar for cystic duct access. So when does lap CBD exploration fail? It fails when the cystic duct is small, tortuous, obliterated, inserts at an acute angle into very distal CBD. If it does that, then you cannot manipulate the guide wire from the cystic duct stump into the bile duct. And if the stones are large and impacted, can cause significant inflammation. So in those cases, you do a transcholedochal exploration. Am I clear? Yeah, we may end it, I think. I mean, class is over. Okay, okay, thank you.
Okay, so thank you so much, Shahana ma'am. It was an outstanding session. Thank you all the students as well for cooperating with us. And if you have any doubts, you can ask here, or you can ask on the WhatsApp group as well. Thank you so much, everyone. Thank you so much.